dermatology specialist clinic and a few other hospitals, right? Tung Shing. Tung Shing. Alright, okay, so without further ado, Dr. Hao.
Thank you very much, Dr. Azra, for the kind introduction, and thank you everyone to be here today. So I think like what Dr. Azra had rightly pointed out, that atopic dermatitis, the main bout is actually mild to moderate diseases rather than the moderate to severe. In this era of JAK inhibitor and biologics, we are always emphasizing on that. But how many of us can actually be put on JAK inhibitors and as well as all these biologics, and they can continue to use it? Even if they are under control, they will fall back into this group of mild to moderate, and you will eventually need to do something else for maintenance subsequently as well. So that's why it's very crucial for us to be able to manage this group of patients, because if you manage this group well, they either won't deteriorate further, then they remain stable, or those that are severe initially, they will eventually become the more easier to control and remain in remission subsequently as well. So this will be my conflict of interest and the agenda for today. So what have been mentioned earlier on is that the mild to moderate diseases is like 60% is actually the mild diseases among the adult patients. So, and as for the children also, you can see that among those that are actually 6 months to 6 years, 6 to 12 years, so whether they are children or whether they are adults, they are all pretty much similar, that we are treating mild to moderate a lot more. So subsequently, like we are talking about all these IgA, I think just now have been very, they have been mentioned by Dr. Cheng about all this, so it saved my time. So generally IgA 0 to 2 and is the one that is going to be mild, and moderate diseases is the IgA of about like 3. So why do we need to emphasize on this mild to moderate diseases? Also is about the quality of life impairment that we are having in terms of these patients that are suffering from mild diseases as well. I would like to bring your attention to the center one. These are the mild diseases, whether you are looking into different type of quality of life impairment, whether it's a DLQI, whether it's a child DLQI, whether you are looking into SF36. I am not so sure about this. I tried to search it, but I don't really get it much. But it's a visual analog skills. But you can see that although it is not as much affected compared to the moderate to severe, but it is still more significantly affected compared to those who are the control. So it tells you that even the mild to moderate diseases patients, it doesn't mean that they are okay. Even every time when these patients walk into your clinic, you still have to ask them how do they cope with their daily life. Is there anything that you would like to ask me, and whether there's anything that I can help you further, and if there are any questions when you are dealing with your emollients, dealing with your corticosteroids and all these things. So the challenges in managing mild to moderate diseases will be on these few aspects. I think one thing is the steroid phobia. So a lot of patients, they are able to get their disease under control. But the thing is that because of the steroid phobia, they are not using the steroid rightly. And after that, eventually, it becomes more worse and worse. That is at least what I experienced. And when I address this steroid phobia, patients usually get better control. So this one is one of the main challenges, I would say, that in dealing with atopic dermatitis. The second one is the treatment complexity. So how many different type of moisturizers that you prescribe? The face is different, the body is different, then the emollient is different. Then you have a Eucosan for the face, you have a Mometasone for the folds, and then you have a Adidel for your eyelids. Then you have a BBO 0.1% for your palms and soles. It's even among us, sometimes we find it very difficult to understand that as well. So simplifying the management is one of the main treatment challenges that you need to address as well. So for me, I usually try to use something else that they can use like for whole body. So I like something else, like maybe just like Eucroson or Mometasone, and I like to use something else that is able to be used just once per day rather than 2 times per day. So sometimes you want them to like use the lips 3 times per day, you want to use them 2 times per day over the body, once per day over the night. over the face like that. So these are things that makes the whole treatment complexity. So please address this part as well. So subsequently, that there's a very frequent flash, and why do they have experiencing these frequent flash later? I think I will just show you a little bit of a picture about how a wildfire is, and hopefully that you can bring into your treatment strategy and addressing about all this proactive management in terms of the usage, and why do you need emollients when you are using that, and why is it so important for you to address the flare at the right time rather than waiting it to become worse and worse. Alright, so you can look into whether it's a Malaysian guideline or whether it's a European guideline. Generally, they are the same. You need emollients, you need the bath practice, you need educational. And I think the most important thing in mild to moderate is again educational. So we do see people hopping from one doctor to another doctor to another doctor. Ask yourself whether you are doing better than your clinic kesihatan doctors. Are you prescribing anything different from them? You are prescribing EcoScript also. You are prescribing your BDO 1 in 4, 1 in 2 as well. So what are you doing different? So the whole thing is that you are able to explain the disease better compared to them. You are going to spend more time to tell them what exactly is happening. That is what your role is as a dermatologist. You are not doing any better. All this wet wrap therapy, do you think that the GP don't know? They know that as well. So do they don't know about Elidel or Protropic? So it's about the time that they spend with the patients and eventually address their concern. That is the main thing that you need to learn to deal with that. Okay. So just now, Dr. Chung had mentioned about reactive and as well as proactive management, and these are going to be covered later. And we'll also talk a little bit about wet wrap therapy, because I remember that when I started training, when we're dealing with wet wrap therapy, there are a lot of misconceptions that you need to use the wet wrap therapy for 24 hours, and then you kind of force the patient to continue to use the wet wrap therapy regardless whether they are happy with it or not, and you just prescribe them without asking them whether it is something else that is going to help them or make them worse. So you have to remember this, there's no one size fits all disease management, so you have to really depend on what exactly that you are using. Alright, so in the management of atopic dermatitis here also, I think it's generally the same thing across whether it's an American, European or Malaysian. The only thing that is different, there's some newer agent that they are using is that the PDE4, but we are always going to get PDE4 maybe this year or next year, I think by Pfizer, right? Next year, yeah, maybe next year. So it will be coming in soon, so we will be also touching on this PDE4. Topical JAK inhibitors are not going to be addressed in this particular topic here. Alright, so now the story about our forest. Okay, I think we like this kind of very green, when your moisture is sufficient, when the soil is sufficiently moisturized, everything grows very, very nicely. But if you lose your moisture, that is your epidermal barrier that is going to go off, then you don't have all these things, eventually everything starts to die. But at this moment, do you see any inflammation? You don't see any inflammation. So at this point, if you continue to shower them with all these moisturizers and everything, they will eventually start having all the greens coming back out again. So this is the right time that we want to catch them and also to address them before they turn into like this, okay, like a wildfire. So when you are having a wildfire, you can have a very small fire like what you see here, or you can be a very, very big fire like this. So when you are using your corticosteroids, what you are going to do? So sometimes you are using like, okay, I'm so worried about my water, so about the usage of my steroids, okay? So I'm going to use just topical first when the fire is like this. So you are sending these people going into the fire. So do you think that the person is going to tahan that or not? So the exudative type of moisture steroids, they are going to get all the steroids coming out. So you see that as exudative. So Dr. Chung mentioned about wet eczema. Okay, when it's exudative, you apply anything, it's just going to push out whatsoever away. If you use it to keep on emphasizing on that. So sometimes when it's a very angry fire like that, you have to use systemic for a short period so that they are able to get in better control. Then with that, topical is going to touch them. So also, if this like this, so it's time for you to use something else more systemic for you to treat the patients. So when we're treating them also, sometimes we say that, oh, we're so worried about the water going to flood the forest. So when the fire comes down like this already, then you say, okay, never mind, we wait for the thing to go off. This is what the patients are always thinking. They think that it's getting better already, then it stops. And a lot of patients are talking to me like with eczema. So they're telling me, oh, I've been having that 3 months, 3 years already, but it never get better. Okay, it can only get better control. So I always ask them, what do you mean by better control? So when they tell me better control, it means that it's still dry, it's still flaky. And I ask them, do you ever see that you have a very good lips before? So then they say, no, never. So it means that you are always treating it like this, then you stop. So the next thing is also whether you are talking about the subclinical inflammation. So when there are a lot of inflammation that are going on for a very long time, then you have all this subclinical inflammation that is happening. So if it's a rapid fire just started, maybe the underground fire is not there. So put off rarely that it's going to have it will go into remission quite easily. But if it's something else that's so long already, it's going to burn down there. And if you don't address the subclinical inflammation, then it's going to have some problem. This is where you are seeing all these flexural eczemas that you are dealing with. These are places that you would like to address your proactive therapy, right? So you are trying to intermittently give water to this area so that you put out the subclinical inflammation. This is your proactive management, the concept of proactive management. So finally, you reach this stage, but you decided not to put anything. So you just tell them, okay, you're fine already, then you discharge them, and you don't give a little bit more time, discuss with them, tell them about, look, now you are in this stage, but if you don't do anything, a single cigarette butt come in, it's going to burn again. So you don't put a moisturizer, you don't address your bathing habits, so what is going to happen is going to go back into that thing here again. So we hope that with a right thing, eventually it becomes like that. Then after that, it goes back into the forest that we are looking into. So a lot of the time when we're dealing with atopic dermatitis, it's about the wrong selections of medications. The site of treatment, when you're addressing your pumps and soles, you use hydrocortisone. When you're using your scalp, you're using hydrocortisone like that. So these are very big areas. So then sometimes we use this kind of mild to or moderate to potent corticosteroids over your inguinal area. So your groin area, axillary area, so ended up with a lot of striae. So these are things that always happen. So you don't know about the severity, you don't assess the severity of the disease, you don't assess the site of the treatment, and you don't understand the potency of the treatment. And if you're using the more severe type of treatment, then also the more potent treatment also, you can always use that even if you are over a thin area, but you have to see them a little earlier because you understand that they are having all these more side effects when you're dealing with using of potent, medium potency or potent or ultra potent corticosteroids. So this one is one of the favorite question, and I believe that even the first year now should be able to tell that we have a UK working party, UK potency chart, and we have the US potency chart. But in our atopic eczema guideline, we basically use the UK potency guideline, and you have to fill in the blank because these are slides that are adapted from globally, and they are maybe used in the UK or the US. But some of the drugs is not available, and some of the drugs that are available here is not available, not listed down as well. So whether to start with a low potency first and gradually get it under control, or you use a high potency and go down. This one, I don't think that there's a randomized control trial to look into that. So which approach is the safer and the more efficacious way. But for my own personal experience, I usually like to use the high potency. I don't know in your, I know the majority of us is in the government practice, but if you start seeing someone else that's having an acute flare, you start seeing them at 2 weeks for the first one or two times. Then subsequently, when everything is under control, then you can distance it up. And so with that, you are able to use this high potency approach for the very beginning. But if you're really very tight in terms of your manpower, if you're unable to do things proper, then maybe you are going to use just the low potency or medium potency, and hopefully that you give them adequate amount of counseling and they will get into remission as well. So hopefully that follows that. The reason of frequent coming out for the follow-up is so that you can address any side effects, even if there's if you are using your high potency. So this is what I mean, that it really depends on whether you are dealing with a thin skin area, whether you are dealing with a thick skin area, whether you are dealing with an acute skin area, occluded area, or whether you are dealing with like frequently one-off area. So just now I mentioned about once per day, but this once per day, can you use it over your lips or not? So sometimes it might be very difficult because over the lips area, you are like frequently having your drinks, you are wiping it off, foods and all this. So if you are applying it just for 1 or 2 hours only, maybe it's not very helpful. So sometimes when I tell them, I'll just tell them that after your food, then there's a time that maybe you can put on all these things. Then it can stay like this for the next 3 to 4 hours. Hopefully that it will give a little bit of results. But if they are relatively okay already, then I'll use it at the night time, because it's going to tell you that patients is going to go to bed. Alright, so it's going to be like the next 12 hours at least, the lips are not going to touch any drinks and not going to have any foods and all this, so it stays a bit longer for the biological effect of that. Another thing about topical treatment, fingertip unit. Please use this a lot. Okay. Sapu nipis, nipis sapu tebal tebal. I believe that Dr. Leong also mentioned this before. So really that the nipis nipis and tebal tebal is a different thing for everybody. So but when you use fingertip unit, when you tell them, look, this area you have to use it about like 2 fingertip unit. I'm expecting you to finish this 1 tube of Eucloson or this 1 tube of mometasone within this 1 or 2 weeks. You will see results, even if it's a severe disease. Alright, I really use this even for my babies as well. So sometimes, but you have to frequently monitor them if you are using the high potency corticosteroid. This is what is very important. So to make time, understand this fingertip unit, understand that roughly how many fingers that you need to use for that. Usually this is overestimate and it's impossible to reduce. So I usually tell them, look, this is what I give you, but I give you some discount, 50%. At least apply 50% of what is recommended here, and I still see results. But if you don't apply this, and you ask them how much cream that they are still holding on, they'll tell you that the Eucloson cream that they give 15 gram or 13 gram is still there for the next 2 months. But the BSA is maybe 5% or 10%. So do you think that they are using sufficiently? They are not using it at all. So this is what are the things that you need to do, not only write the prescription, but talk to the patient, understand how do they use the creams. Alright, so potent and very potent, not recommended in GP, but here everybody is dermatologist to be, or dermatologist, so I think that we can use something more aggressive way of approaching. So we should use it for short period under specialist supervision, frequent monitoring, you will get disease better control. Okay, and the proactive management is important as well. So whether or not using a potent corticosteroids for 2 weeks is going to have any problem. Sometimes we are so worried about that even 1 week we already start asking the patients to reduce the usage of it. So you can see that there's no difference in terms of 2 weeks usage of potent corticosteroid compared to just the vehicle itself. So it's okay. So ask them to use it so that you can get things under control. After the 2 weeks time, if you think that the disease is getting better controlled and you're so worried, taper down to medium potency corticosteroid. Why do I say 2 weeks come back? This is one of the reasons of that. And yes, corticosteroid have a higher risk of skin thinning compared to that, but you have to look into that. Like this particular paper, they are not looking into like every single like 2 weeks or 4 weeks or 8 weeks like that. They are talking about it, and one is actually going up to 5 years usage. So definitely, if you are using it for more than 5 years, the relative risk of getting your topical corticosteroid-induced skin atrophy is going to be very high. So what about once daily and more frequent? Sometimes that there's no meta-analysis, but in terms of that, they find that there's no skin thinning effect. So I personally like the once daily. If they can't really approach that, you have to ask about their occupational as well. So if they are very difficult to use cream during the daytime, at least the night time they have to use it at least once per day. So but if you keep on saying, no, you have to use it only 2 times per day, then they are going to have so difficult and rather don't use anything like that. So they'll go on to another doctor. So tell them you have to tailor your things accordingly when you're dealing with mild to moderate diseases. So 2 times per week as vehicle, so no evidence of skin healing, no biochemical evidence of suppression. We tell you that the proactive management, whether you are using corticosteroids or your topical calcineurin inhibitor, it is still going to be okay as well. Alright? So always adverse events, unless that you are using whole body, then it will have all these hypothalamic, all these immunosuppressions and stuff like that. But if you're just using localized, it's okay. So I always have to tell them that all these things. Localized treatment also, if you're using it just like 2 weeks, get control, tapering, use it for another 1 or 2 weeks, then after that stop it. So you usually don't end up with all these side effects that you are looking at. So far, touch wood, only those very severe, very difficult to control, I will see that kind of a local side effect, but I don't see systemic side effect from our topical corticosteroids at this moment. So calcineurin inhibitor, yes, we can approve. What is important for your question is they are always going to ask, what is your approved age for tacrolimus 0.03%? So yeah, 2 years, pimecrolimus, what is the approved age? So tacrolimus, what is the approved age? So, but in real life, we know that protropic 0.1% and 0.03. We have Dr. Raihan here. I believe that she's not going to use protropic 0.003 as well. So I think she's mostly going to use protropic and only going to go into pimecrolimus straight. So it's only these two usually, because the price of 0.03 and 0.1 is going to be the same. So it's about understanding the cost effectiveness of your drug and whether it's worthwhile for you to invest for that. This is double or triple the price of pimecrolimus. Okay, yeah, if you are using protropic 0.03, I don't know whether it's still true or not, but I think it's still the same price, 0.03 and 0.1%. Correct me if I'm wrong. Okay, so but the efficacy of using it as a proactive management is also okay as well. Long-term using is also okay. So what are the things that we need to know about protropic and as well as pimecrolimus is that they are going to cause burning and stinging sensation. This is, I think, for the second and third year, they are most likely going to know already. Maybe the first year when you're prescribing that, you have to tell that. So they are going to tell you that, especially when you're using over the periorbital area, you are going to have a lot of burning and stinging sensation. So what are the challenges and how do you address these kind of things?
Put in the fridge.
Put in the fridge, any other way?
Moisturizer.
Put moisturizer first, then you put on the thing, third one. Use some steroid first, then followed by that for the first 3 days, then subsequently followed by that. Everybody know about that. Okay, so high potency, low potency pimecrolimus is similar to your hydrocortisone. Your tacrolimus is somewhere similar to your mometasone. So pay attention to this burning and stinging sensation because that is what your patient is going to get. I give you $180 for your protropic, but ended up I can't use it. So they are going to blame you for that, especially if you're doing some private. Black box warning, yes, it's still there, but I think it's already telling you that it's not so much of a problem in terms of the lymphoma things. The safety profile is more than 10 years already. So please advise them, regardless, the black box warning is still there. So you still have to tell them, especially those that you are living in a high medical legal places like KL, PJ. So you are going to deal with these kind of patients, or maybe JB, you are seeing a lot of Singaporeans. So whether they are going to get these people to come in and have these kind of problems. Okay? So remember telling them that, and it's up to their choice to see whether they are going to use it or not. Okay, so far it's not so much of a problem. Black box warning associated with the use of PCI should be discussed. Alright, and crisaborole is the one that you can use mild to moderate AD, age more than 3 months. And after that, generally crisaborole is a PDE4 inhibitor. It has been proven to be helpful. Generally, the long-term safety and efficacy is still pretty much similar to the rest of the things. Burning and stinging sensation is still one of the things that is important in crisaborole, but to be frank, any topical can give you that burning and stinging sensation. Alright, so those are things that you need to observe. And backup therapy, I just want to tell you about the important thing is that not necessarily you need to leave it overnight. So you can use it during the daytime if the patient patient is more comfortable using it in the daytime, or else you're going to wet the thing and ask the baby to go to bed in the aircon, then what is going to happen? The mother is not going to say yes to you. Okay, so you are going to use it depends what type of patients. So some they can use it overnight, some they can use it daytime. Even if it's 1 to 2 hours, it's alright as well. Whether you can use it concurrently with mild, moderate corticosteroids, or you have to use it with potent corticosteroids, so it's up to you. But the thing is that you have to know that this is an occlusion. Once you have an occlusion, that's going to have a lot more complications. So remember about that. Alright? So not for everyone, and sometimes certain people find that it becomes even worsening their eczema. Okay, the duration of application varies, depends on what type of living, housing environment that they are dealing with. And ointment or cream, but some people just tell you, no, you cannot use ointment for your wet rat, but always use cream only. But it's not proven like that. Some of the literature actually tell you that you can use cream, you can use ointment as well. So not necessarily only with the TCS and the PCI, but moisturizer is a must. So best is used for like identified area. You don't have to wrap the whole body, even if it's a localized area, you can wrap that over that area as well. So hopefully with that, you are everything over this time. So that's the time that the emollients comes in. And when we talk about the emollients, I think the main component is 4 things, okay? So the 3 things that is very important is, one thing is actually to moisturize the skin, that provide all this water to it. The second thing is the lipid replenishing, which is the oil that's going to form an occlusion, and also the film forming area. So, and also one more is actually the humectant factor, bring more water into that. So that is the basic moisturizer that you're dealing with the Aquas cream like that. So an active ingredient is the one that gives you becomes like an emollient plus. That's all is currently that we are using in our more in our booth. You will see a lot of all these creams that they are having the emollient plus there because they provide more things. So here you have to understand what is the natural moisturizing factors. You can go into this particular position paper about diagnosis and treatment of cirrhosis cutis for further information and detail about that. There's also another Singapore paper that's talking about moisturizer that gives you all this humectant, moisturize your emollients, and as well as your occlusive, what are the definition, what are the example, and how does it act. So these are things that you have to go back and do some homework about that. Alright, so these are your full forming, and subsequently an active ingredient. It really depends whether it's truly benefit compared to another. We don't know, but we know that then when it's added, it's sometimes better than the vehicle. And a lot of clinical trial for moisturizer, very important for you to pay attention to, is that they don't necessarily have a placebo control or vehicle control. So sometimes they are single arm, and even the vehicle sometimes gives quite good results as well. Okay, so whether about all these active ingredients is a combination of multiple active ingredients inside, and you don't know what exactly is it like every single of it have an effect, whether it's a synergistic effect, and all this everything is not really properly addressed when it comes to moisturizer. Alright, so but saying that emollient plus are found to be more beneficial in the short term and the long term outcome of that. So efficacy wise, a short and long term steroid sparing effect can be achieved with a regular use of emollient. There's a systematic review and meta-analysis talk about that. Also, whether an additional urea into it or whether there's any other things into it, they don't find any extra benefit, but moisturizer itself is definitely going to be better. Alright, so hopefully with that you are able to bring the patients to here. And lastly, you are trying to address about the allergens. These allergens, I think the most important thing is house dust mite only, and the rest in terms of the foods, I think we all know that foods is not really one of the main trigger in atopic eczema, unless that it is a child disease, childhood atopic dermatitis, which is very difficult to control and have an atypical presentation. So those are the ones that maybe you have to look into whether there's some other allergens that you may want to address. Okay, but the rest of things, I believe that by now you have managed at least 6 months of atopic dermatitis, so it should be quite okay for now. Okay, so take-home message, very important. If you look into your atopic dermatitis guideline, the traffic light thing, what is that thing? Education there's a traffic light stop. What's the education? I'm not speaking of the question. Eczema action plan. Yeah. So the eczema action plan, you have to really look into that because they actually tell you treat till clear. Okay, it's not 2 weeks, it's not 4 weeks. Because if you don't treat till clear, what is going to happen is like what I've shown earlier on about the fire that is partially treated. Partially treated things is going to come back. So side effects, things will go back eventually and they will eventually get better as well. But if the inflammation is not properly addressed, there will be some problem. Okay, so wet therapy is very helpful, but not for all. Fingertip unit is very important. Please try to address fingertip unit. Not all emollients are the same. So, but generally, the good emollient is the one that is going to help the patients to induce remission, prevent relapse, and reduce corticosteroid usage. And which is the best? I will tell you that there's no one that is better than other at this stage. So it depends on the viscosity, the feeling, and their nature of work and their preference. So the one that is going to be used every single day, that is the best moisturizer for the patients. Okay, so no one size fits all for all topical. So you have to really discuss with the patient which type of treatment that you are wanting to use. So make time, look into the steroid potency chart, understand all these things, and look into their personal preference, whether they like cream or ointment. Don't decide for them whether they want ointment or cream. So, and the disease severity, and after that, it's also addressing the environment. That's very important. All right, with that, I think I'll end my topic. If you have any problems.
Thank you, Dr. Howe, for highlighting the importance of topical treatment in management of mild to moderate AD. Any questions for Dr. Howe? Yes?
What are your thoughts on using wet wrap for erosive and oozing lesions?
It's a contraindication, right?
It's not the slide there shows that use until oozing clear.
Oh, okay. So maybe I didn't read through every single thing.
Wet dressing, I think wet dressing lah, probably, you meant because sometimes maybe a bit confusing, wet dressing.